Hello, everyone. Thank you all for joining us today. Welcome to our launching event organized by OR Society Special Interest Group, OR in Practice. My name is Nalan Gülpınar. I'm chairing this SEC and currently working in Durham University Business School. Today, we will talk about implementing OR for better healthcare systems. We have 5 panelists. And before I invite Christina Phillips, who will be facilitating our panel discussion, I would like to briefly introduce our special interest group. The SIG OR in practice aims to create a platform to disseminate knowledge and understanding of OR approaches to structure complex business problems, develop models, and propose solutions for real-life decision-making problems of complex business systems. Here today, we are talking about healthcare systems. The ORP network supports collaboration between OR practitioners and academics, and especially builds bridges across academia and industry, connecting professionals from diverse sectors. We aim to foster collaborative research between the OR community, especially encourage efforts between academic groups and industry partners. In summary, the OR platform aims to help OR practitioners and academics to make further impact for a better world. We have been talking about some housekeeping issues. You heard that already. This session has been recorded. We encourage active participation in this session. Please feel free to share your views with us. If you have any questions or any comments, you may use the chat box to submit your questions or comments. And if you have any issue, please don't hesitate to contact us. And during the session, we will try to address all of those questions, or we will leave some of them to Q&A session at the end. For any technical issues, we will try to resolve it as soon as possible, and we will join to session again. Now, it's a big honor to introduce Dr. Christina Phillips to introduce our valuable panel members and lead discussion today. Thank you very much.
So, first of all, thank you very much for all of our panelists for coming today and for accepting our invitation to come. And thank you, Nalan, for actually having the idea of starting this SIG, because I think it's an absolutely wonderful thing to do, to try to develop a SIG that is specifically aimed at trying to bring practitioners and academics together to use OR to solve real problems and to get us to focus on the reality of what we do, which I think is just a wonderful idea, which was why I was very happy to be part of it. For all that I'm stretched across other SIGs already. But yeah, we will do more between our SIGs at some point and be a powerhouse. So the first thing I'm going to do is I'm going to go around all of our panelists and ask them very sweetly if they would introduce themselves and where they're from and what they do, so that we can actually understand the context that we're operating in. And then I'm going to aim a couple of questions specifically at the practitioners in the room to ask them about their experiences in healthcare and the things that they feel OR could possibly help them with. And then the last 2 questions I'm going to throw out to all of our panelists to hopefully start creating a really good discussion around the issues facing people, how OR has been used, how OR could be used, and how things like design principles can actually help us to grapple with this space a bit more, especially when it comes to things like knowledge transfer and actually designing OR so that it fits the situation, which I believe a couple of our panelists in the room have actually done. So, first of all, really important bit, can I ask you one by one, I'll call out names to make it easier. Who are you and what position do you hold? And I'm afraid, David, you're first on my camera. So yeah, I'm going to ask you first to unmute and tell us who you are and what position you hold.
Thank you. So, first of all, it's a pleasure to be here. My name's David Elderamy. I'm a consultant physician. I'm a jobbing clinician. I've also been a clinical manager since 2004, and I'm currently trust lead for research, and I'm the Health Innovation in West Midlands Clinical Director. Thank you.
Thank you, David. So next up on my camera is Lucy.
Sure. Thanks. Hi, everyone. I'm Lucy Morgan, and I'm an OR practitioner. I currently I'm at the strategy unit and also a visiting researcher at Lancaster University. My background is in simulation modelling and methodology. Yeah, that's me.
It's lovely, thank you. And next up on my screen is Gary. Gary, if you could.
Hello, I'm Gary Fothergill. I'm currently semi-retired, which is fabulous. By the way, thank you for inviting me. I think it's a real pleasure to share my 20 plus years of practicing in the NHS. So I'm currently semi-retired. I've worked in just about every facet of healthcare, from acute, primaries, ICBs, NHSE, and the Health Foundation as well. So I've got a pretty varied view on life in this little enclave.
Thanks, Gary. So next up is Jeff Royston.
Hi, folks. Yes, I'm Jeff Royston. I guess I'm also semi-retired these days, but for about 20 years, I was head of profession in the OR group in the Department of Health and the then NHS executive, ending up as head of strategic analysis and operational research there. So I think I've seen a fair share of the problems in the health service in my time. So we'll see as we go along today.
Thanks, Jeff. And last, definitely not least, is Guillaume Lamé, joining us from France.
Hi. Yes, I'm sorry, an associate professor at Centrale Supélec. It's the engineering school of Paris-Saclay University. And I do research on the organization of health services in between design, operations research, and human factors, mostly in cancer care and maternity care.
Thanks, Guillaume. So first of all, I'm going to throw these to the practitioners in the room. I think I might include Jeff in this as well, because I think he recognised quite a lot of the problems that David came up with. What are the issues you face in relation to resourcing? So I'll start with Gary, and then I'll come to David and then Jeff.
So I just jotted down a few things. So I've been a practitioner in healthcare, for, like I said earlier, for about 20 years. I think down at an operational level, and I've predominantly worked in an operational setting, people in and around the NHS who are delivering care don't know what OR is and don't see the value in OR. Mostly what you see is people that have got analytical skills tend to be sat in teams in a little ivory tower, and they're knocking out sort of dashboards of count data in fairly sort of rudimentary graphs. They don't get out into business, and that's the key thing for me as an operational researcher. My first manager was the chief operating officer at Big Teaching Hospital in Yorkshire, and he saw the value in the skills that I had, and he just gave me carte blanche ability to go out, work with teams on the ground, start spreading some of the OR type skills, methodologies, some of the techniques, and challenging some of the fairly naive methods that get used in an operational setting. So I've got very fortunate in that I've been encouraged to share those skills with people that are delivering healthcare. So I've worked in just about every facet of healthcare, from the front door to the very back door and beyond. As I said, analysts don't get out into the business. They don't understand the business. And I don't think they have the skills. They don't have those skills that we as operational researchers would call the fundamental skills. And I think from a recruitment perspective moving forward, why would you as an OR graduate want to go into an industry where your skills aren't appreciated? I think there's something about the NHS has got to get a bit smarter about understanding what OR is, how it can help, and starting to mandate that when problems arise in organisations, that they have a team of people there that can apply the right techniques to solve those problems. My organisation in Acute were quite fortunate because I'm a simulation model, so I'm like Lucy. So, looking at some of the naive methods that get used to calculate bed capacity, for instance, they're laughable, and yet these are being used to deliver care to very sort of sick people, and they don't facilitate efficiency. The mundane methods and naive methods they use create a lot of waste. They don't optimize what the resources we've got. Beyond that, if you're going into an NHS organisation as an analyst, the core skills that you need and that are valued are you can manage people, you can write SQL, you can do a Tableau dashboard, and you can knock something together in Power BI. There's no optimization, there's no simulation, and most people don't know what those are because they don't know about OR in general. So it's one of these things where the NHS doesn't know what it doesn't know operationally, and that's not just a thing for Acute. You see it in primary care. It's rife in NHS England. I've worked in NHS England, and some of the stuff I've seen at NHS England, honestly, make you want to cry. It's that bad. So it's not just the secondary, the care delivery part of it. The overarching umbrella of NHS England, I don't think helps either. So they're my sort of observations of this area. The NHS just doesn't know what it doesn't know about OR, and that's the key thing for me. If you don't know what it is, how can you value it, cajole it, and build it when you don't know what it is?
Thanks, Gary. Thank you. So next up, I will ask David. David, what are the issues you face in relation to resourcing? You had quite a lot to say on this one.
Yeah, no. First, I just pick up Gary's point. So I think as a general statement, first of all, I'll speak within my own profession. So clinicians are often asked to take on management roles, as Gary will be familiar with. And I think it's fair to say that most of those clinicians who take on those roles, first of all, don't have a proper time allocation for those roles. They don't have proper professional development, and they don't have mentorship. So I think the deficits that Gary's highlighted in OR, I think extend across most areas of what you would call clinical leadership. And that's not a criticism, that's just an observation. So I think that if we then move on to OR knowledge, I think most people would have very limited understanding of simulation, very limited understanding of Tableau, very limited understanding of Q theory, very limited ability to model things. And yet, as Gary said, you'll have those same people deciding whether a hospital needs an additional theatre or, a significant resource. So you've got people who may not necessarily have all the background skills in quite senior positions where they're considering quite sizable investments with limited resources. If we then come downstream from that and we assume a degree of competence, if we just assume that as given, the problem you have is you actually have a very fluid situation that you're trying to manage. So not only do you often not have the skills, timing, or resources, but you often don't know what the challenges are likely to be, and you don't know the resources that you're going to have, particularly on a day-to-day basis. And then if you think across the NHS where those problems are most pressing, they're often in the least where the uncertainty is. It's often in things, for example, like acute care, where it's very difficult to respond. Your timeframes for response are actually quite limited. So if say for example you're looking at say hip replacements, elective hip replacements, you have people queuing on a waiting list, and that's a waiting list that you may be managing electively. And although it's not good for people to wait, you actually have some capacity, some time to actually think things through. With guidance regarding cancer performance and the pressures associated with that, you have much less flexibility. And then when you actually move down to things, for example, like emergency care, you are really in a very tight situation where you're making decisions often with very limited information, very limited skills, and you're not even certain how many people you're going to have either coming in requiring the care or how many people are going to be providing the care. And even if you know the numbers, it's very difficult, say, for example, if you're at a large teaching hospital, to know the variation in the quality of the people who have been appointed. And that's not a criticism, but when you say, for example, I have a doctor who's going to be covering a space on a rota, that person could be quite senior, very capable of working independently, or could be new to the hospital and actually need a great deal of support. So I would echo everything that Gary has said, but I would add to that even if you have a good theoretical knowledge, the practical situation is quite challenging. I don't know if Gary would agree with that.
Absolutely. It's interesting when you start to share some of the methodologies with clinicians. It's interesting that because they've got a more scientific background, they tend to embrace it more than you would an NHS manager. So I built up a fantastic friendship with a clinician who is rheumatologist by doctorate background, but he completely gets the OR sensibilities and has become a big advocate of operational research. But what you're talking about with regard to understanding demand, I did a locum recently to an NHS hospital quite close to me, and they were using a moving 4-point average for their forecast for A&E attendance. I put in a machine learning model using, I think it was Profit, I think I used in the end. And they wouldn't engage with it at all. And it was far more accurate than what they were using. Your forecast horizon was much longer, took into account holidays, all that type of stuff. They just would not engage with it. And it's because largely, I think you find that a lot of managers who are running services, and this is quite derogatory term, but a lot of them are statistically illiterate. And some people might sort of balk at that, but that's my lived experience of majority of managers in the NHS who I've dealt with.
I've heard that before from a doctor, actually, who was my gynecologist. Would you believe it? Who wanted me to come in and teach them statistics, but she couldn't get the funding for it, unfortunately, which never mind. Because I said, I can teach people statistics who don't like statistics. She went, oh, you've got to come here. But, there you go. Anyway, I shall now pass over to Jeff for this one. So resourcing.
Okay, well, fascinating to hear Gary and David speak there. A lot of echoes of things that I recognise, and these other people recognise. I've just dug out something that was written in the editorial in the British Medical Journal over 20 years ago by Terry Buhag. I'll read it to you. Compared with many other organisations, hospitals have been slow in adopting operational research as a means to improve their performance. Applications are scattered and results are not always used, even if they're relevant and reliable. the implication is that so far hospitals have largely failed to use one of the most potent methods currently available for improving the performance of complex organizations. So you know, we're still there up to a significant degree, I think. In terms of resource issues, I think yes, of course, resources are tight, time is tight, money is tight, everything's tight, always has been, and I guess always will be. In the real world, that has to be recognised, and our analysts have to recognise that managers operate in that situation where there is variation, there is uncertainty. In particular, there's non-linearity. I think managers and clinicians recognise the variation and uncertainty. I think the relevance and importance of non-linearity is underestimated. Too much thinking about resources is done on what I'd call the floor of averages. That was a Russ Ackoff phrase, I think. Seeming you can run anything on averages. I remember we had an ongoing row with the Treasury for some years about bed capacity in hospitals. They thought every hospital should run at 100% occupancy, otherwise we were wasting resources. And we took ages to get them to understand that the price of responsiveness was actually having some spare capacity, because you had a non-linear system, a variable system with uncertain demand, and unless you were prepared to quite often have to turn people away, you needed some spare capacity. It wasn't wasted resources, and that basic concept was not understood even at the sort of high levels of the Treasury. In fact, the way we got it understood was not by doing any modelling, or we did all the modelling, of course, but the way we got it understood was by thinking about the language we used. And I think the language is an important feature here in trying to get messages about resourcing and analysis across, trying to actually get it into the language that managers and clinicians will understand and recognise. So we talked about not slack and or even non-linearity. We talked about the price you have to pay for being responsive, and they understood responsive. I think when we put to the question, how often do you want us to have to turn people away from hospital, they got the point at that, because when they said, well, never, and we said, well, we require the entire budgets of the United Kingdom and more in that case, and that led to an interesting discussion about what non-linearity and uncertainty in health services meant. So I think actually just recognizing that there's going to be problems with resources and getting people to understand quite why and how and what you could do about it. And just as a shortage of resources can very rapidly lead you into deep problems because of the non-linearity, look at A&E departments, look at ambulances, look at what happened with ambulances queuing outside hospitals. Instead of waiting for 15 minutes outside hospitals, they're having to wait half an hour. That meant that their response time to meet emergencies, you're effectively taking ambulances out of service. Their response time, instead of being the standard 8 minutes, or in practice more like 15 minutes, shot up to an hour, 2 hours, 24 hours even. So getting people to understand what's going on there, and understanding the good news is you can run that backwards. If you can just get it down a bit, just get a bit more resources in there, you can get quite a rapid and major improvement in performance. So I think getting a common understanding of some basic principles is actually quite an important foundation point here. So I will say more about such things later, but maybe that'll do for now.
That's wonderful. Thank you very much, Jeff. I think that rounded off that bit of conversation beautifully. There were some other points that David came up with in the initial discussion on this. Uncertainty, I think you've covered very well, and the fact that things are pretty pretty non-linear. Barriers to flexibility, I thought that was quite interesting. So actually it becomes difficult to be flexible because there are barriers to that flexibility, perhaps partly due to a lack of systems awareness. Innate structures, I think that also feeds into that lack of flexibility. And he gave us a nice example, which was delivering an insulin injection to a ward patient. The injection is seen as a specific professional's task. So the willingness to do that depends on the role and not just the skill. But of course, it's unpredictable because you've no idea what the acuity of patients are going to be coming in on the ward, or the uncertainty regarding the staff capacity that you're going to have at the time. So that's a nice example of how that inflexibility starts to play out when you're actually in action. So the next question, which I'm going to throw to just the practitioners in the room with some experience of this, is tell us about the day-to-day challenges you face in operations across healthcare, And I will start there with David.
Sorry. First of all, really interesting to hear from Jeff before we move on to the next thing, because I think for people on this call, it is quite frightening to hear that people even at a treasury level don't understand basic concepts of capacity. Sorry, Gary, you've got your hand up. Do you want to come in there? Or
Yeah. All I can say, David, is it's exactly the same at NHS England as well. So as you go up the hierarchy, it's exactly the same at every level.
I mean, that's just interesting, because I'd always hoped that at some point there was an understanding, but you've kind of broken my heart there. So that's unfortunate to hear. I think, first of all, if we accept lack of understanding capacity is a major challenge. An unpredictable demand, a lack of finance. One of the things that you're often constrained by isn't just performance, but also the opportunity to actually use money to try and solve the problem, as well as an access to resources. For example, even if you have money available, you can't always get the right skilled people to come in. You find yourself on a day-to-day level you then end up in a situation which I call a tipping point, where you have inefficiencies due to a lack of capacity, which makes things even more inefficient. And you can then end up in this spiral where you end up with excess expenditure due to the fact that you're having to bring in clinicians who are not used to the areas that they practice in, often on a locum basis. Then you end up with reduced quality. You end up losing a collaborative, well-established team. Then you can end up with difficulty attracting and retaining people to deliver the care. And it can sometimes become quite a vicious circle. So it starts off as an issue of where you haven't planned your capacity, your demand properly, confounded by unpredictability, confounded by pressures, and confounded by constraints both on financial and clinical resources, can end up almost as a very destabilizing effect. And that idea of non-linearity, I think, applies very much to the negative impacts of when things don't go well. So you don't have a predictable situation where, say, for example, you have one team member down and things are difficult, and then you have two team members down and things become very difficult. Things can tip quite unexpectedly into a very difficult situation. If I pause there, Christina, would that be helpful?
That's wonderful. Thank you, David. I think that's a very, very interesting point. So I will throw that over to Gary now.
All right, okay. So I think day-to-day challenges, I think Jeff talked about it earlier, is about the language. It's really, really important, trying to get some of those quite thorny and difficult concepts over to managers is quite difficult. And I think that's something not to be scoffed at. I think on a day-to-day challenges, I think most of the modelling that I've seen in my career has been pretty naive. There is no concept within that modelling. There's no concept of uncertainty, variation, as Jeff alluded. And when you try to bring that into the mix, it's really difficult to get people on board, because you're taking them into an area that they're uncomfortable with. Because I talked about managers being statistically illiterate. Once you start putting them in a situation where you are explaining things that are above their comprehension, and that's no disrespect to them, because they've been brought up through a particular way through, and GMTS is a great example of that. They tend not to engage.
Yeah, I could tell you're going to get right on one there. So, Jeff, I'll pass over to you, and then I'll start opening this all up to the floor.
Well, I'll sort of continue with the thoughts about the sort of reality of the healthcare system, and maybe we've sort of had a go at managers to some extent. Let's look at ourselves a bit, perhaps analysts, and what analysts perhaps fail to do. We've talked a bit about using the right language, but the sort of day-to-day challenges are to do with people and to do with complexity. And I remember reading a book by the management guru Peter Drucker, who had a chapter in his book in his famous book on management, which was about management science, as he called it, and he excoriated management science for not being serious about their subject. And I thought hard about that and looked at what he said. And what he said is that management scientists tend to, produce models and lots of wizard mathematics and so on, and that's to ignore the reality of their subject matter, which is systems and people. And I think OR has been very slow to recognise that, and it's particularly important in any service industry, so to speak, like a health service. I was delighted that behavioural OR has begun to, in the last 10 years, begun to take off, recognising the importance of how people behave, how clients perceive us, how the subjects of our systems actually behave, how we recognise put behaviour in models, etc. So I think to deal with day-to-day challenges, you need to recognise what they are and the complexity of them, and the fact that people are involved, and that sort of also gives a clue to some of the solutions. Like, for instance, I did about 10 years ago a paper which was rather hubristically titled 100 Years of Operational Research in Health, but it pulled out a few things that I thought we could look at harder. And one of them was to get powerful champions. And I think that an earlier comment sort of indicated the importance of that analysts working in their ivory tower will tend to be stuck in that ivory tower and be given tidbits of unimportant problems to deal with if they're not careful. If you can get signed up to a powerful champion, and I totally take the point about clinicians who can be perhaps the best powerful champions because maybe they recognise the science a bit more. Get a powerful champion mind, then you can get involved in important problems. If you get involved in important problems, you can do important things. So I think that is a key, another people aspect. Getting involved with that. And another day-to-day challenges thing, which is also a sort of people thing, is what are the problems that the managers and clinicians are actually most worried about? Not the ones you think are most important, but what are they most worried about? Because what is being written about in the Health Service Journal at the moment, or in whatever, the journals managers read, not the journals that analysts read, or even the journals that clinicians read, but the journals that managers read, things like the Health Service Journal, what are they writing about? What's worrying them? So getting involved in their problems, their day-to-day challenges, getting a champion to actually lead on those challenges to help you get involved at the top. I think we'll come later, Christina, on to how that relates to design, but I'll leave that for a bit later, perhaps. But I think that's real-world day-to-day challenges involves people, what they're worried about, and getting on that track. I'll stop that line. Sort of one line of thought.
That's marvelous. Thank you very much, Jeff. That actually rounded that so beautifully. Yeah, bringing design and systems back in again. Yeah, which was part of the kind of idea for today, is bringing up these other ways that we can engage that will help us to do it more. So I'm going to throw questions out for everybody now. But what I think we've brought up some really, really interesting stuff there. Before I ask the other questions, is there anything that our other panelists would like to add to what they've heard? Nope, not yet. Okay.
Sorry,
Anybody else?
I'm just going to come in. I think that managers are working under intense pressure.
Yeah.
So I think if any comments have come across as what you might call in inverted commas manager bashing, I think that first I would say that certainly I don't think has been anyone's intention. Secondly, I think the support they have, I spoke about clinicians, but I think the support that managers have for training in OR it's clearly very limited. And I would even, I'm very fortunate at the trust I work at. We have a fantastic director of finance, really do. So I think maybe I've been blessed. But I think the financial pressures that organisations are put under sometimes doesn't bring out the best in people, and I would frame it that way. And I don't think that. So I think that complexity is something that does need to be considered. But I hope that is helpful.
Can I just to make a point about that, David? So my acute trust always balance the books. Put a massive amount of importance on finance, and I think it's that driver from top down that generated the behaviours that I shared with you about the admitting. Yeah.
No, I'm agreeing with you, Gary. I think we're on the same page. But what I meant was, I think that these are, it's an example of the complexity of delivering healthcare. And the pressures that are often external. I think we're saying the same thing.
Yeah, I think we probably are. I think it's just it's coming at it from a slightly different angle, David.
So just to sort of quell your worries there. When Gary said that, I did actually put they worry about finance, and rightly so, because that is what they have to worry about. Somebody's got to worry about that, and that is their headache. I think the problem is we're not very good at putting a value on things other than money, and I think that's a societal issue and not necessarily an NHS issue, and that hopefully is something that our society will overcome over time. But as it is right now, it's the manager's job, isn't it? So in my notes it does actually say that I've been kind to managers, yeah, because they've got a damn hard job as well. So I'm going to yes, Jeff, yes, you
Can I
can.
just add a very quick comment to the one on managers? Because I think I was quite hard on managers too. And as I sort of went up to a more senior post and saw more senior managers, I slowly understood what enormous time pressures they are under. And managers at the top have an almost impossible job, and just a staggering amount of correspondence and stuff crosses their desk. And well, put it like this: Winston Churchill said, "However important the topic, whether it's about the overthrow of the country or whatever, I want the submission on one page of A4." And I eventually understood why he said that.
And in my experiences, this is why managers love averages and don't like things to say, well, actually, in this circumstance, we need to consider the median and the average. They go, why do I want two measures? I just want mum that tells me what I need to do. So it's a difficult situation from a statistics point of view as well, isn't it? So I'm going to throw everything open to the floor now. And I think first things first, I'm going to bring Guillaume in and ask him, what is your experience of trying to implement solutions for systems improvement in healthcare? Because I know you've got experience of that.
Of implementing anything, not that much actually. I watch others try and often fail, and that's what academics do, I guess. I was thinking about this while listening to others as well, and what we do in OR. And there's not, I mean, I speak from France, there's not that many OR practitioners in healthcare in France. In fact, I can't cite any, so it's only academics basically. And I think we've fallen in the same trap as many other, as we have in many other industries of, bringing ever more complicated algorithms to problems where I have an example here. So we have was discussing the other day with students who are trying to launch a startup looking at nurse scheduling. So nurse scheduling has been on the agenda in healthcare OR for maybe 50 years. And now we've reached the point where, you produce the new algorithm that's going to gain like 3% of something, and you add ever increasing sources of uncertainty, et cetera, et cetera. Basically, they were gaining lots of contracts from hospitals with something that a student in his first year coded using constraint programming or something. That was absolutely basic, but the hard bit was not the algorithm itself. It was, getting all the interfacing with the computer system in the hospital. It was getting all the systems so that, one, you get all the data regulation right, two, people don't have to double, triple, quadruple type the data in various different bits and pieces, which keeps happening everywhere in those things. So it was making this into a simple plug and play situation. I mean, I guess then as they have more clients, etc., they will run into issues of making the algorithm more efficient and better, etc. But just doing this, they were saving 1 or 2 days per month to the nurse manager in every unit they worked with. And you kind of think, I've seen nurse scheduling presentations at every healthcare OR conference I've been to, and I've never heard of any of those systems actually making it into practice in the hospital. Maybe I don't listen well enough, and maybe some people are doing it, but I haven't seen it in any French hospital I've been to. Then the issue is, I would be bored to death having to work through those issues. It's not my job as an academic to do this. It's probably not any operational research practitioner doing this. And then we fall into the gap where we have those wonderful methods and algorithms. And that only addresses part of the OR playbook, because I know that when we talk about simulation, we don't want to implement simulation models as decision systems or things like that. But I think there's clearly a gap here in transfer and implementation, that these students are going to succeed. They're going to make money. They're going to sell it to lots of hospitals. And I'm kind of wondering why no one has tried it for the past 30 years, because the algorithm they use has really been there for 30 years. So there's clearly an issue there with those things, I think. Moving from those clever bits of optimization and modeling into something that actually fits into the day-to-day system. And design is kind of the opposite. It's like whatever the means, as long as it works and produces something that's better than what was there before, we're kind of happy with it. But then design researchers are not rated on the quality of their algorithms. So yeah, I don't know if that really answers the question, but
So I was frantically typing there, especially that last bit. So design tends to look to improve, but it can take you up the garden path. It can take you up completely the wrong path because of that, because actually, although it might have improved in that one context, what it didn't do was improve and integrate.
yeah,
Or
possibly.
I misinterpreted.
I mean, I think if a design person was to look at those problems, most of the time they would not worry about the quality of, the perfection of that algorithm, and they would probably be very happy taking something off the shelf that's 30 years old and only improving the situation by 15%, when the most up-to-date method could do 50% or something like that. But then working out all the bits and pieces that move this from that brilliant idea into something that actually improves anything by 15% is not something fascinating, but might actually improve those bits by 15% rather than theoretically improving the stuff by 50%. So yeah, I think that's the focus on actually delivering something practical, which again, I'm not blaming anyone. It's not really academics' jobs to deliver software that works in hospitals and integrates with electronic health records. But we might want to think about whose job it is if we want our stuff to get into practice one day.
And we might want to think about how we can help people to implement things in ways that work for them. Perhaps, yeah, that might be something that we need to think about. And Lucy just dropped out then, so I hope she's got back in again all right. Lucy, are you there? Okay, I'll hold off for a moment with Lucy until she's able to get back in the room. Are you there, Lucy?
I'm here now, yeah.
Have you had a chance to implement stuff in healthcare to date yet? Or are you working on something perhaps? Yeah?
Yeah. Before I started at this job, when I was at Lancaster University, I did some work with the air ambulance that got implemented, and meant they trialled after work we did with them a nighttime rapid response vehicle, and then that actually is on duty now, and it's quite nice because it's obviously contributing to saving people's lives in the region that I actually live in, which is a nice thing. I think one of the things that I was thinking as the other people were speaking during the session was that quite a lot of people have mentioned that people don't have this knowledge of OR and optimization, simulation, etc. And I have found that people do come to universities and do come to consultancies like the strategy unit for that type of expertise, and they're not necessarily looking to learn those techniques themselves, but there has to be some kind of go-between where they understand the model enough to be able to implement it and to trust it enough to be able to use the evidence that it gives across. And I found that using like participative simulation has been a really nice way to build that trust and build that understanding as you go through a project, and use their knowledge to validate those models and show them at different points during the project that the model that you're building is representative of their system, and this is how it can help, and that type of thing. So although I do think it's nice for people to have a basic understanding, and find that clinicians are very, very clever people and do come along on that journey very well, they don't need to know everything, the ins and outs of simulation or optimization, to be able to work with us as OR practitioners, and I think that's a good thing.
Yeah, absolutely. Having that trust that's what we want, isn't it, really? If people could trust us a bit more, that would be helpful. But then you've also got the situation where, you know, if you don't understand how the AI came up with the answer, then you can't really sign it off, can you? So we've got to find that balance in the middle. So thank you very much, Lucy. Good to hear from you. So next I will bring in, let's change the order of things, Jeff. Talking about implementation of OR. You're on mute, Jeff.
Thank you. Got it. I think I mentioned earlier on that work has been done looking at the implementation of simulation projects showed really rather a low implementation rate, although I remember, I think it was Sally Brailsford pointed out that that's not entirely the whole story, because some of these research projects, and you wouldn't expect them to have 100% implementation rate. Implementation, I do feel quite strongly about this in general, however, that OR is, you know, it's a science of better, it's an improvement science. Its job is not just to understand, that's important, its job is to improve. And I would say that's true for academics as well, in a somewhat different way. An algorithm that sort of purely of abstract interest has its place, but it must be kept in that place, and it's a subsidiary place in my view, compared with something where you really are bringing about an improvement. So I think that suggests that if you're trying to bring about improvement, then you've got to think about what counts as better. Some people might have different views about what an improvement is. It's not always uncontested. You've got to think about how much you're trying to improve something. Are you thinking about the sort of the Pareto 80-20 rule? Where is that 20% of effort that will produce 80% of the results? So don't dissipate that. Are you thinking about sustainability of improvement? I learned a lesson some years ago. One of the first projects I was involved in the health was outpatient waiting times, and we produced a guidebook in the Department of Health with lots of good stuff about how to reduce outpatient waiting times, with a supplement on modelling, so you could do quite a lot without modelling, but if you wanted to do a Rolls-Royce job, you do some proper simulation modelling. And we went round the country and various departments to pick this up. And then maybe 10, maybe even 20 years later, I was sitting, not as in my professional capacity, in a personal capacity, in an outpatient department clinic. It was actually an eye clinic, and I noticed that it was a bit chaotic, and everybody had been waiting a long time, and it was quite apparent to me that they'd broken the first rule of managing outpatient patients, which was not to get your patients to arrive half an hour before any consultant did, or that means they automatically wait half an hour plus, and then half an hour plus. And as I sat there thinking, well, they've not read the book, or if they have, they're not. It suddenly struck me, well, of course they haven't read the book. That guidebook was produced, 10, 15, 20, whatever years before. Since then, there have been 7 or 8 generations of outpatient managers. Well, what is the chance that at some point, even if the first manager looked at that guidance and followed it, that they passed it on to the second one? And even if they did, what's the chance they pass it on to the third one? Somewhere that chain's got to be broken. And it suddenly struck me that if you're trying to improve something in the health service, it's a bit like, teaching the dangers of smoking to teenagers. You've done the 3rd year. Yeah, you've got to do the 3rd year again next year, because next year there's another 3rd year, next year there's another 3rd year. I don't think there's many things in the health service that you can do an improvement just once. I think you've probably got to keep at it, or at least think of a way of making it embedded so it's sustainable, and that's much more difficult than doing a one-off. So I think there's issues there about sustainability and improvement. There's issues about contested improvement. There's issues. I was interested in the point about participative simulation. you know, a pure abstract model isn't going to get very far with hard-nosed managers or even quite keen clinicians, probably. You've got to get them signed up. One of the best simulations I saw didn't involve any modeling as such at all, or at least not at the early stages. What it did, it got every professional in the chain, from ambulance paramedic to receptionist in the outpatient department, to the consultant, to the all the staff, about 15 of them, involved, and got them all in a room and got them to try to draw a map of a patient pathway, which they did by somebody pretending to be a patient and going along from one person to the next and saying, what do you do to them? What do you do to them? What do you do to them? And then they produced a complex system map in a way, and from that they did some simulation modeling. But I think 90% of the value of that 2080 rule again was from that participative mapping exercise, and that stuck with people because they realized what other people did and what they did and how it all fitted together, which they'd not realized before. So I think that's enough for me for a bit, I think.
Thank you, Jeff. That's ideal. Yeah, that really resonates with my experience. I think Lucy's as well. Yeah, I seem to remember having conversations about this. So next, I'm going to bring in Gary.
It's an interesting point, Jeff. I'll just sort of dovetail your points about mapping. Mapping is a fundamental part of the work that I've done all the way through my NHS career. So given that I'm quite interested in building simulation models, you know, it's a great starting place, and especially getting all the people in the room to draw out that map. And I think it's quite enlightening for those people that don't know what people are doing a little bit on further down the chain. And I think it's quite good as well for bringing together people and developing relationships, that they do know that something they do on their patch might have a direct impact on what somebody further on down the line does. So I think just getting that communication and knowing who these people are, even if it's just putting a name to a face, saying hello, sometimes is really, really important. So I think that mapping thing as a collaborative tool, I think is really, really important. And that was something that was done significantly well in the early 2000s by the Modernisation Agency. So they put a lot of effort into all of this, and they released some guides, the little sort of A5 books that were really good. And it started to, if you have a look online, you'll find them. They're in PDF form. But they start to describe things like basic queue theory, but it's done in a very sort of very simplistic way. It's really well written, and there's all sorts of sort of games that you could play. It's a bit like you were talking about your mapping session, where you get people in a room and you play the dice game, and you introduce them to things like variability and uncertainty, and about how planning on averages is not very good. And it's talk about, you know, being as you put it, sort of non-linear. So there's that. So I don't know if it's something to check out, but they did a lot of good work around using measurement for improvement as well, which people who are doing improvement sort of live by. A lot of people are changing stuff without a sort of QI methodology underneath, just change stuff and don't measure it. And I think that's not a very good thing. The one thing that Gilliam mentioned, and he talked about scheduling and somebody writing a really good algorithm. One thing that has been a problem for a number of years, and before I came into the NHS, I actually worked for one of the big computer system suppliers. So I was a senior software engineer for a company called McKesson, a massive company, and they did PASS systems, and I think we got a system in just about every trust in the country. But one thing that was really bad then, and I don't think's really improved, is interoperability. So, you know, getting into that system to be able to apply the algorithm to do all that good stuff, the access and, you know, being able to get there and get in is really difficult. And that's one thing. And also, the NHS has become memoryless, and that's a point that Jeff made, where, you know, you've got to improve things 2, 3, 4 times. All that really good work that was done by the Modernisation Agency in the early 2000s, those people that were the disciples of that push have all retired. And that's not been updated by people that are backfilling these people. Last thing is I worked for quite a long time for the Health Foundation doing the AAA program, which is an applied analytics. This is about getting more OR, more analytics into high level analytics into healthcare organizations. And what we try to do is, rather than just bringing somebody in to do it to them, we put a lot of emphasis on getting the people who got funded to actually learn to do it for themselves as part of the project. So if you were bringing in some guys to do simulation modeling, what we were trying to do is to say to the people that were bidding, part of your bid must be to get some of those skills into your organization so you can carry on that legacy.
That's fantastic. Thanks very much, Gary. So last and definitely not least, I'll ask David about implementation issues.
No, I think that's really interesting, what Jeff and Gary were saying, because I was downstream of those health implementation programs. So I'll give you a specific example to put some flesh and bones on things. So in about the year 2000, it was decided that we ought to try and reduce the incidence of bowel cancer, particularly. So there was a program that came out called a bowel cancer screening program. So there was all the medical evidence for it that you could detect bowel cancer in asymptomatic patients, and if you did, it would be cost effective. But what you then had was you had proper implementation. So I was a newly appointed consultant, and we actually had sessions across the UK about what we were trying to do. We had political and financial alignment. So in other words, the money was available. We had professional bodies that supported the implementation. So we had buy-in from the key stakeholders both, and we also had buy-in from patient bodies. So we got all the, what you might call human factors were resolved. Then what you had was you had proper modeling where people would say, this is what we would expect. This is what the number of, in an average population, this is the number of patients that you might expect to complete. This is the variation you would expect. This is the range of colonoscopies that you might have to be performed. This is the number of operations you might have to perform. And I think it was probably the only example in my life where you really had things go from start to finish, done what I would call in inverted commas properly. There was a rolling program to maintain the standards so that it wasn't as if it was just dropped into a service and then left on its own. It was continuously monitored, and it had ongoing support both politically, financially, and from professional bodies. And so it was something that's actually changed to the extent now that previously, when say I was in training, we were used to people presenting with bowel obstruction due to bowel cancer. It was quite a common presentation. The actual incidence of that happening across the UK has gone down because of this program. It still happens, but it's less common. The incidence of early cancers being detected has gone up. And so I think for people who are looking at OR and people who are looking at healthcare, the opportunities to do some really interesting work is definitely there. On a much smaller level, I think, for example, we've looked at theatre capacity within our hospital. We've looked at mapping bed capacity. And again, going back to the framework about language that's been spoken. So what we have framed these as is, if we can predict the bed capacity that you will need, you can have the right number of people on the shift so that you don't have someone walk into a shift, say on a ward, and it's hell because you've got many more patients than you expected. You don't, for example, have a theatre list that predictably runs over because you haven't used things properly. And I think if you were to take a step back, I know that we have our finance directors are concerned about the money, but the biggest certainly one of the big challenges is actually retaining staff and retaining motivated and happy staff. And I think I'm very fortunate because I think the trust I work at appreciate that. And I think certainly even without being asked about financial benefits, the idea that we can try and improve things but by making it predictable and reduce variation in finish times and theatres, etc., has been very attractive for staff and for the trust. And certainly that's a piece of work that we're hoping to take forward with Nalan, having done the mathematical modelling, is actually take it into the implementation. I'll pause at that point.
Was that what you meant by language? Because you started that comment with language, about language, but I presume what you're saying is you're doing something with Nalan, but you're going to want to then translate that so that it becomes easy for everybody to understand in terms of their daily context.
I think for a start, if you want people to support you, you need to say what is actually important to that person. And if you say, for example, to a nursing team that there are days when you have colleagues finish a shift and they're exhausted, or they've had a very difficult day because they've had to turn away patients that they hoped to admit. And what we can do is we can take something that's important for you, we can use established techniques, and we can reduce the likelihood of those problems occurring. We can reduce the likelihood that you won't be able to admit a patient. We can reduce the likelihood that you'll admit 10 patients on one day and nobody on another day, and have people walk away feeling as though they were exhausted on the first day and the second day was much lighter. So it is about framing things. And I think from an organisational perspective, if you can retain motivated staff by using OR techniques, it's a huge boon. Even the fact that you're trying to do it is welcomed, because I think sorry, I'll pause there.
No, that's spot on, David, as long as you've made it clear to them that that's what you're doing. So it's actually talking about what it is that you're trying to do and involving those people who you're trying to do it onto in that conversation. So that really brings me back, and I'm going to have to bring Guillaume in the room again because he's a designer first and foremost, and then an OR person. So how can OR analytics or design improve the decision-making challenges? And it was just that mention of context that just made me think of you, Guillaume, because it's very much a design way of looking at things, isn't it? Speaking to people's context.
Wow. That's a very big question.
Well, maybe I could make it a little bit easier. What's missing from what people are trying to do?
Yeah, I think there's already an issue here that designers don't really look at decisions. They want to build artifacts. So they want to build a system, a process, a product, whatever you want to think about. But it's something like this. So the concept of decision is absolutely not central, I think, to design and to designers. So if they were to look at the kind of questions we look into, either they would go through the whole mapping exercise we described to design a new process without going through all the modeling we would do, because, well, that's not what designers do. Or they would try to look into ways to build a nice decision support system, again, without having the skills to build the algorithm that's at the center of it. I think operations researchers, and again, it's going to be a lot of generalities here, but would tend quite often to focus, and I've heard a lot on simulation here, but I think simulation is quite strong in UK operations research. But if I go to a French operations research conference, there's probably almost no simulation. It would be 99% optimization, scheduling, queuing theory, and things like that. So I'll probably have a bit of a bias here as well. Would focus very much on the algorithm. And again, job done once that proves on paper with historical data that you can do 70, 80. I mean, those orders of magnitude are clearly not unreachable in healthcare, better than the manual method that's prevalent. Well, is there a gap? I think we wrote a paper a few years back with Jeff, and I think I saw Sonia Crow here in the crowd as well. And I think Jeff has been thinking and talking about this for way before I was even in the game, about working together to address these issues, because clearly we don't look at the same bits. And Jeff, you said earlier that, well, OR should be about improvement, even academic OR, it should be about improvement rather than modeling or algorithms or anything like this. But there's so many incentives everywhere that push us towards certain directions, this form of tradition, of habitus as well, that builds up. And I don't know exactly what could be the drivers for better collaboration. There's probably, it is clearly something to do with software companies as well, as mentioned earlier, because yeah, I keep turning around the same concept, and I'm only tackling part of what OR does and what the issues in healthcare are. But yeah, and I don't know how to make us work together better. But the potential is definitely absolutely there, and there are cultural differences between, operational researchers and healthcare, well, either health professionals or healthcare managers, but that rift also exists between those sort of improvement disciplines, and I think there's some work to do here as well, to do that. Yeah.
I think you actually very nicely pointed out what we both got missing, and therefore what we could really add to each other's disciplines if we work together a bit more, or it's just some extent, try to understand what each other does, and the value of that. But maybe we all need to be a little bit more solution focused. Yeah. So at this point, I really want to bring in Lucy again, because Lucy actually left academia. I'm not quite sure what her motivation there was, but I know maybe the same reason that I've been looking at the door quite a lot is because you actually wanted to make a difference. Go on, Lucy.
Sure, yeah. Do you want me to say why I left academia, or probably not? Sorry, Christine, you're on mute then.
Sorry. Oh, you don't have to do what you want. Yeah. The question was, how can our analytics and/or design improve the decision-making challenges, which is a huge question in itself. But I think I think the rabbit hole that Guillaume has opened up there, where we've got bits missing from each other and we've got bits missing from how we interact with practice, would actually be a very interesting line of discussion.
Sure, yeah. I think something that I've noticed since I've come into working in a more, I guess, closer to practice role is how big the gap is from between the academic challenges that I've been trying to address, which were more around uncertainty in simulation and operational research, and trying to make simulation a better tool and something where we understood the error in it a bit more, to actually doing things in practice where you don't often, because of time constraints, you don't have to often get a chance to explore those types of questions that often. So I think, yeah, on this side of things, it is the questions are often quite different, but I do think the advances in things like AI and machine learning and the new approaches that are coming through because of those are almost, I guess, closing that gap, but maybe not in a way where people fully understand the methods that they're using. So it almost, there's a little bit of a danger there also. But yeah, I think my experience was from leaving academia, it was driven by the need or the want to make more impact with the type of work I was doing, and healthcare seemed to be the thing that I enjoyed most when I'd actually done academic work and academic consultancy. So it seemed a clear front runner for me for my move. I think I probably can't speak to anything on the design side because I've not done anything there, but yeah, I'll leave it there.
you'd be surprised at how similar your approaches were to Guillaume's approaches when you were doing the ambulance work, and when Guillaume's been doing some of his work in hospitals as well. You probably have a lovely long conversation if you meet up. And some great things to share. So I'm very aware that we are running out of time. We've only got 10 minutes left in the meeting. So Gary, I'll turn to you, and I'd like to throw it open to the floor as well, if that's possible. So if anybody's got anything they'd like to say, please do put your hand up, and then I can bring you in. Gary.
It's just a point. I've been worked with, there were a program many years ago called Plethora, and I've dropped it in the chat. And I think Jeff and Sonia, definitely Sonia was, I think I met Jeff at the conference at the end of it many years ago. So there were a couple of things that I just wrote down about what could be done. And I think Department of Health differs significantly from NHS England in that they've got a strong operational research element in their function. And I think when DHSC subsumes NHS England, that I think the department's got a really crucial role to play in starting to get some of that OR capability that's up there and to get it into healthcare delivery organisations. And I think there'd be something around is once, if we can get some of those skills down, it might be good for DHSC to actually audit organisations about how they've arrived at the decisions they've arrived at and what methods they've used. Because if you look at some of the methods I've sort of come across over the last 20 years, they're horrendous. And, you know, and I'm not just picking on, it's just not knowing that OR's there. And if the department can say, look, if it can put together a program like David alluded to with bowel screening, in that we get that program, we say to the hospitals, look, there's a skill set and a toolkit here that could help you deliver better care for patients, then here it is. We want practitioners at your organisation to embrace it and use it. And what we're going to do is periodically, we're going to come and have a look how you're making your decisions and whether you're using these tools. I mean, it's not in every case, but, you know, when you're doing big capacity things, you know, let's make sure that you've done the modelling, you know, let's see that you've done a simulation if need be, or you've done the scheduling using an appropriate means. Because if we don't, we're not going to get those skills. Something's got to change. Because if we carry on, we're just going to carry on doing the same thing. Like Jeff alluded, you know, it's that sort of, hey, just sort of tumbleweed just blowing through the organisation year after year after year. So I think the department in the next couple of years got a big opportunity to start to push OR as a product into healthcare organisations to say, look, these are tools you should be using. And I just want to pick up on a quick part of the academic versus the practitioner. In the academic world, you know, you want to have that 100% watertight case that goes into a paper. In healthcare, sometimes 90% is more than good enough. And it's having that little bit of a grey heuristic area that it doesn't have to be perfect, but as long as it does the job for the patient, it doesn't matter if it's not watertight and not good enough for the paper. It's good enough to get that patient through that system quicker and treated more effectively. And sometimes that's what we need to be aiming for, not perfection.
So I haven't had any more hands come up from our audience, so I'm going to throw this back to David again, so now our last 5 minutes, because you could tell us what you'd love to see OR analytics or a design approach do in your trust, in your particular experience.
Yeah, no, thank you. So I think if you look at what we're trying to do, is make the best use of the resources we have, financial, clinical, to deliver great care. And if we then say that OR isn't about deciding what those priorities are, I think there is a role for OR in saying, this is what you want to do. This is a way of understanding. It is a way. it is not the only way of understanding the system that you've got currently. And it is a way of a lens for looking at where you're trying to get to. It then provides a tool for the people who are trying to produce the change and make things better. It doesn't work single-handedly. We've already said that we need consistency with regard to resource, we need political stability, we need to allocate, all those other things. We're not forgetting human factors, we're not forgetting all those other things. But what I think it does is it can provide clarity. It can tell you, for example, that if you double the resources, it doesn't guarantee that there won't be an ambulance waiting for 4 hours. So it gets rid of such silly things that it just makes life easier. It's a bit like we spoke about numeracy, but I think it takes away a lot of the inaccuracies of projects that are put forward. It brings them into a way of actually giving an honesty about them that doesn't predict the future, but at least it gets rid of what I would call extreme optimism or extreme negativity. It also saves you a lot of resources. I would suggest that in a perfect world, you would say that a person should not be able to put forward a business case without demonstrating some understanding of OR. That would be my suggestion. If I put forward a business, I can't sit on an interview panel without being trained in equality and diversity. I can't do lots of things without saying that I've got some vague competency in what I'm doing. And then if you say that resources are valuable, demanding that basic literacy, not expertise, but basic literacy, I think would be helpful. And I think embedding that in the same way that we wouldn't allow a trust board not to have someone looking after patient safety, we wouldn't allow a trust board not to have looking after staff well-being or all those other things. I think those basic skills, having them through the organisation, from the very basic level, I think that a sister looking after a ward should be able to explain to the staff the basic concepts of variability, the basic concepts of what's predictable and what's not predictable. That should be a basic requirement. And everyone coming to an organisation like a healthcare service should be able to understand that. Not mathematically, but at least the concept-wise.
Yeah.
And anyone taking on a leadership role, I think, should almost have to demonstrate capabilities within that, because the resources are important and what we're doing is important. That would be my very simple suggestion.
I love that. It sounds like human-centric analytics, doesn't it, Nalan?
I couldn't agree more with that, David. That is such a pertinent point.
So definitely music to the ears of everybody in the room who's an OR researcher, because we'd love to see more people knowing about OR and stats and basic skills in that stuff. And you are right, it does encourage people to lay everything on the table and to be much more honest. So I'm going to hand over to Nalan to finish off the session. I would just summarize by saying I saw a few things come out very strongly there. Designers and operational researchers need to work together to understand how they can engage people better in these processes and how they can do the end design of artifacts that work and that get implemented and that have a sustainability in practice, as Jeff said. Everybody needs to know a bit more about OR and stats from the bottom to the top. And would say particularly at the top, because if they're trying to put forward ideas and ways of doing things, then they need to understand what could go wrong and everything. And OR especially needs to help in healthcare when it comes to understanding and mapping uncertainty and trying to reduce the amount of uncertainty that people are coming across every day that makes their jobs extremely hard. So I will leave it there unless anybody's got anything that they really want to shout, and hand over to Nalan to finish off our session.
Great, thank you very much, Christina. First of all, I would like to thank all our panel members. We appreciate really your time, your engagement, your contributions, your insights and your experiences really enriched this discussion today. And we learned a lot of things from you today. And I really, really appreciate it from each of you. And I also would like to thank each of you for joining us today and for your participation. We really appreciate for that too. And our SIG is still ongoing, and we will be still organizing new future events. And please join our SIG, Operation Research in Practice. And I'm looking forward to welcoming you again at the future events. Once again, thank you all. Take care. And yeah, thank you. See you soon. Take care.
Oh, and one last thing before you all go. If you're not a member of the OR Society, please consider joining, because
Yes.
we can't keep doing this good work without the people back in the OR Society. Thank you.
Thank you all.
Thank you. Bye-bye.